The pressure scale is on the horizontal axis and the compliance scale on the vertical axis. When the membrane is clamped, the compliance is low. As the pressure is lowered, the compliance increases quite sharply and then begins to fall again as the pressure is decreased below that of the middle ear. The point of maximum compliance is clearly seen and in a normal patient is at 0 millimeters of water. Let us continue with the actual test. The pressure scale is raised to 200 millimeters of water. The machine is set at low sensitivity, scale 1, and at a high impedance. The pressure is then gradually lowered and the compliance meter observed closely. The pressure reading at the point of maximum compliance represents the middle ear pressure and is recorded. Next, the acoustic impedance is measured. With the pump adjusted to equalize the canal and middle ear pressure, the compliance control is turned until the bridge is balanced. This gives a total compliance measurement for the mobile tympanic membrane and acicular chain, as well as the ear canal, and this is recorded. The pressure is now raised to 200 millimeters of water to clamp the tympanic membrane. The compliance control is moved until the meter is again balanced. Since the drumhead is clamped, this in effect establishes a compliance reading for the canal alone. When the figure for the clamped position is subtracted from the figure for the canal and mobile chain, the difference represents the compliance of the mobile tympanic membrane and acicular chain and is recorded in cc's. The acoustic impedance can be calculated from a formula using the alternative figures, and in practice is read directly from a normograph in acoustic ohms. Various disease processes grossly affect both the pressure and compliance readings. In a patient with serous otitis media, in which the eustachian tube is obstructed and the middle ear filled with fluid, the middle ear pressure will be low, often around minus 300 millimeters of water, while the acoustic impedance will be high, for the fluid dampens the mobility of the membrane and acicular chain. The impedance bridge provides an excellent means of following the course of serous otitis media to complete resolution, as compliance and pressure readings return to normal. A high acoustic impedance occurs whenever the acicular chain is fixed, irrespective of whether the fixation is of the tympanic membrane or of the acicular chain itself. For instance, it is found in patients with otosclerosis, where the anchored stapes effectively immobilizes the acicular chain, impeding the passage of sound. Here, of course, the middle ear pressure is normal. Not all patients with a conductive deafness and an intact tympanic membrane have a high acoustic impedance. If, for instance, the long process of the incus is necrosed, the tympanic membrane and acicular chain is much more mobile than usual. It absorbs sound more readily, and the acoustic impedance is therefore abnormally low. To distinguish otosclerosis from an interrupted acicular chain is of considerable clinical value. Contracture of the stapedius muscle tenses the acicular chain and also increases the acoustic impedance. A loud sound introduced into one ear causes a reflex contracture of the stapedius muscle in both ears. The ear under test is the one with the earphone. Contractures can be detected swiftly and easily by the impedance bridge. The bridge is set to a sufficiently high sensitivity, 3 or 4. When a loud sound is introduced, contracture of the muscle appears as a movement of the balance needle and can also be recorded on a strip recorder. The threshold for the reflex is determined at several frequencies. In the normal, it is at least 80 decibels above the pure tone threshold. In patients with cochlear damage, the stapedius muscle reflex threshold is closer to the pure tone threshold, a difference of less than 70 decibels being significant. The results match very closely with those of the CC test and are quicker to administer. Tests of stapedius function aid in establishing the level of a facial nerve paralysis, for if it is above the nerve of the stapedius, the muscle will not contract. When testing facial nerve function, the ear with a probe becomes the ear under test, for here the efferent arc is in doubt. As an adjunct to conventional audiometric techniques, this instrument provides considerable additional information and is simple to operate. Young children tolerate it well, and here it is helpful in determining the presence or absence of hearing and the presence or absence of fluid in the middle ear. It assists in the differential diagnosis of conductive deafness and is of great value in unraveling the diagnostic labyrinth of sensory neural hearing loss. It establishes the presence of cochlear irritability quickly and easily. Finally, perhaps its most valuable feature is that it does not rely on patient response. It provides an objective method of assessing the function of the middle ear.